a very good evening on behalf of the Classroom series of NCSI. I welcome you to today's Journal Club. The topic for today's Journal Club is Association between Induced Burst Suppression and Clinical Outcomes in Patients with Refractory Status Epilepticus, a 9-year cohort study. So this article is from Neurology Journal, May issue 2023. It's by Fish et al. From Switzerland. So when we talk about the topic of status epilepticus and the pharmacological measures, so once any seizure is established into status epilepticus, beyond a point it goes into what is called a refractory status epilepticus. Why is this really clinically important is because when we look at the outcomes even with the best possible therapy, as and when patient progresses towards refractory status epilepticus, the outcomes remain very, very poor. So if we look at what is the treatment for refractory status epilepticus is IV administration of anesthetic drugs. So this study looked at IV administration for 24 to 48 hours with the aim to end RSE. So usually this is the aim of therapy when it comes to managing refractory status epilepticus, and usually the seizure is monitored with EEG. So what is the endpoint? So what should be the EEG surrogates for RSE? So there are guidelines which depends and which describes termination of an RSE as either cessation of electrographic seizure or the emergence of a therapeutic burst suppression or an attenuation pattern or an isoelectric curve. But the recommendation for the establishment of one specific of pattern is still not provided. So again, this remains a gray area in management of refractory status epilepticus. So a multinational survey identified burst suppression as the preferred titration target for intravenous agents in refractory status epilepticus. So if we look at the burst suppression, there has to be an interburst interval of approximately 10 seconds, or should we aim at suppression attenuation proportion of more than 50%? So the question lies here, should we aim at interburst interval or should we aim at the overall suppression of the EEG? So with this background, this study aimed to investigate the frequency of induced burst suppression during anesthesia and whether burst suppression was associated with specific outcomes in patients treated with intravenous anesthetic drugs for refractory status epilepticus. So if we look at the methodology used in the study, standard approval protocols were followed. So this was a cohort study, so all the guidelines according to the strobe checklist was kept in place. The consent was waived due to the retrospective nature of the study, and it was a single-centered study conducted at the ICU University Hospital of Basel, Switzerland. If you look at the data collection, so data collection actually is part of two ongoing trials. So this is a part data collection from the status epilepticus unicenter population study and the refractory status epilepticus treatment quality and efficacy of coma induction study. So this study protocol is data collected from these two ongoing trials. So if we look at the time period, this was data collected over 9 years, and it recruited all consecutive patients of refractory status epilepticus admitted in this hospital during this time period, all adults. Now there are few data which they collected. So first is the demographics, where they looked at the age, sex and the disease. Next is they looked at severity scoring. So since all of them were admitted in the ICU, they looked at the SAPS-2 and the Apache-2 scoring. They also used the STESS scoring. So this is nothing but the status epilepticus scoring. It looks into 4 parameters. One is the level of consciousness at onset, the seizure type at onset, age at onset, and the history of seizure at onset, whether prior seizures were present or not. So it is scored 0, 1. Higher score means worse, it's associated with worse outcomes. Then they also collected data on the duration of mechanical ventilation, any complication which resulted because of therapy during the ICU stay in terms of organ failure, infections or hypotension related to IVADs, that is intravenous anesthetic agents. Clinically, they looked at the GCS, the etiology of RSE. So when we look at the etiology of RSE, it can either be fatal or non-fatal etiology. Then they also looked at what was the drug therapy used, what were the anti-epileptics used, what were the anesthetics used, and whether vasopressor use was there or not. And they also collected data on ICU stay, hospital stay, death, and return of neurological function prior to the occurrence of the events. So all the definitions were by the ACNS, that is the American Clinical Neurophysiology Society Standardized Critical Care EEG guidelines. So when you define a EEG in terms of bursts, so it has to have an average of more than 0.5 seconds and 4 phases should be there and up to 30 seconds. And if we define suppression or attenuation, in this study it was defined as either less than 10 microvolts, or if it's more than 10 microvolts, less than 50% of the higher voltage background activity is considered a suppression or attenuation, and the proportion of this one should be between 50% and 99%. So these were the criteria to define burst suppression in this particular study. So the recording protocol was pretty standardized. They used 256 Hz using 21 superficial scalp electrodes according to the 1020 recording system, and a minimum of 1 hour recording is taken as a continuous EEG recording. And during the 1 hour interval, the first 2 minutes was analyzed. So what was different about this study is, instead of using algorithms to assess, they had 2 individual observers to look at the EEG and then identify the patterns. If there was any discrepancy between the 2 individuals, then a third assessor was called in to categorize the EEG. So they defined 3 patterns. One is complete burst suppression. So you can see the figure here, which is defined as more than 50% of suppression, and that means in a 2-minute epoch which was seen, at least 60 seconds has to be suppressed. So this is pattern 1, which is complete burst suppression. The second is incomplete burst suppression, which means that burst suppression is present but the duration is not adequate. So it morphologically resembles a burst suppression as I defined previously based on the criteria. However, the proportion of suppression was between 20 and 49%. So that means in a 2-minute echo, it was between 24 and 59 seconds. And the third pattern was absence of any burst suppression. Here you can see the EEG where there are no patterns of burst suppression, and less than 20% epoch is considered a absence of any burst suppression. So these were the 3 patterns which the assessor has to categorize the EEG which he is assessing into these 3 patterns. So once it was done, also the definition of RSE. So in this study, the RSE was defined based on the standard guidelines. So based on the type of status epilepticus, there is T1 and T2. So an refractory status epilepticus is when a person continues to have clinical or electrographic seizure after receiving adequate dose of an initial benzodiazepine followed by a second line anti-epileptic drug. So this was taken as the working definition of refractory status epilepticus in this study. So the anti-seizure treatment, so the protocol in this hospital was they followed the stepwise approach for treatment of epilepsy. So the first line was benzodiazepine, second line was levetiracetam, lacosamide, valproic acid or phenytoin. The third line was intravenous anesthetic agents, propofol or midazolam. Apart from that, non-sedating anti-epileptic drugs like pregabalin, zonisamide, topiramate or perampanel was used, and the monitoring was continued up till either there was cessation of seizure or a burst suppression for 24 hours. If the seizure persisted, then barbiturate therapy was used. So this was the protocol used for seizure control in this particular study. Now, how did they define the outcome? So the primary objective in the study was to see what was the frequency of induced burst suppression during deep anesthesia. So that was the primary objective. The secondary objective in the study was to see whether there was an association between the presence and the duration of burst suppression with predefined endpoints. So what were the endpoints in this study? One, either the patient should not have no recurrent seizure after this treatment with IVAD, or what was the in-hospital survival, or how many patients returned to pre-morbid neurologic function at hospital discharge. So these were the secondary endpoints considered in this particular study. So after data collection, how did they proceed with data analysis? So for the data analysis, so refractory status epilepticus, the patients were divided into 2 groups, whether burst suppression was present or absent. Then the burst suppression group was further divided into complete burst suppression or incomplete burst suppression. So effectively we had three groups. One, there was no burst suppression. Another where there was complete burst suppression. The third group, there was incomplete burst suppression. One thing was they excluded patients with anoxic brain injury from the analysis because, as we all know, the etiology of refractory status epilepticus is independently associated with a very high mortality if there is anoxic brain injury. So if we look at the statistical methods used, they used Stata software and they fixed P less than 0.05 to be significant. And the descriptive data, they either used median or percentage to describe the data. For analytical data, they either used chi-square test or Fisher exact test for qualitative data. Quantitative data was analyzed with Mann-Whitney test or Crusoe-Wallace test based on the normality. And once this basis analysis was done, whichever was significant, it was done into an univariate analysis, and finally a multivariate logistic regression model was inferred. So this was the data analysis plan for this particular study. So if we look at the results, so during the period from 2011 to 2019, there were a total of 526 patients admitted in the ICU for status epilepticus. So out of which 364 were excluded because patients were treated without anesthetics. Now we have a group where patients with refractory status epilepticus who were receiving anesthetics, that had 162 patients. Out of that, some were excluded because of care withdrawal, or there were missing EEGs, or refractory status terminated rapidly. So finally, the final population were 147. In 147, patients with anoxic injury was divided again. So we had patients with RSE with no anoxia as 102 patients, and with anoxia as 45 patients. So this was the final population available for analysis. So now if we look at, so here you can see in the bar diagram, blue represents no burst suppression, yellow represents incomplete burst suppression, and green represents complete burst suppression. So they have divided based on the proportion of patient and the etiology. So first, looking at non-fatal and fatal, we can see that predominant of the patient, more than 50% of the patients did not have any burst suppression in this subset. Now if we divide based on brain injury from anoxia and focal NSE, again predominantly more than 40% did not have any burst suppression. Now looking at status epilepticus with motor symptoms, more than 78% did not have any burst suppression. And if you look at the stress score, which I described earlier, with less than 3 and more than 3, again the number of patients without burst suppression was very high. It was more than 60%. So the duration of burst suppression in the study, mean was around 22, median was around 22 hours. So from this graph, we can see that more than 60% of the population actually did not have any burst suppression pattern on the EEG studied. Now looking at the demographic profile of the patient, now if you divide the patient into no burst suppression and any burst suppression, the population was almost comparable. Okay, the median age was around 62, females were around 49 and 40%, and the GCS, what was the GCS score as status epilepticus onset, was pretty low. It was 6 and 7. So the groups were almost comparable even in terms of status epilepticus etiology. Now if we further divide any burst suppression group into incomplete burst suppression and complete burst suppression, age had a significant difference. We found that older age group predominantly did not had incomplete burst suppression when compared to no burst suppression or complete burst suppression. Other demographic characteristics were comparable. Now looking at the illness severity, we can see that the Charleston comorbidity index was more in the burst suppression group compared to no burst suppression group, and also patients who had motor symptoms with status epilepticus was more in the no burst suppression group. So these two parameters were different between the groups. Now if we further divide into incomplete and complete, again the stress was significant. We had higher stress scores in patients with incomplete burst suppression, and again the motor symptoms, if we look there, the percentage of patients with motor symptoms had no burst suppression. So these were statistically significant. Now looking at what was the intravenous anesthetic agent used. See, if we look at the no burst suppression, predominant usage was midazolam or propofol. And if we look at any burst suppression group, The combination of midazolam and propofol was used in 31% of the patients. So if we look at the complication rates also, the arterial hypotension rate was higher in any burst suppression group. So if we again divide into incomplete and complete, the complication rate was obviously higher in the complete burst suppression group. Almost 61.9% had some amount of arterial hypotension which required inotropic support, and 14.3% in this group to achieve complete burst suppression required barbiturates also. So this was how the demographic, clinical characteristics and drug therapy was when we divided the population. Now what is it with the outcome? So when we look at the outcome and dividing the patients into burst suppression plus and burst suppression, no burst suppression at all, the median ICU stay was comparatively more in the burst suppression group. The hospital days were more in the burst suppression group. Duration of mechanical ventilation was more, and the number of patients who were monitored with continuous EEG was more in the burst suppression group, and the cumulative median duration of EEG monitoring was also more in the burst suppression groups, and all these findings were statistically significant. Now let's look at the outcomes in terms of when odds ratio was calculated. So we look at three outcomes mainly: whether persistent seizure termination was achieved, second was in-hospital survival. So if we compare between any burst suppression and no burst suppression and complete burst suppression, there was no statistically different. Again, now the most important thing in the analysis is, so we found few confounders during our univariate analysis. We found that the age, Charlson comorbidity index, RSE or motor symptoms were significantly different between the groups. So these were all controlled for before calculating the odds ratio. So that tells us that whether there is burst suppression, minimal burst suppression or no burst suppression, it did not affect persistent seizure termination in hospital survival. And the third thing was return to premorbid neurological functions in survival. Again, whether patient was burst suppressed, minimally suppressed or no suppressed, there was no difference in this outcome. And this was in patients who were analyzed removing anoxic brain injury from the population. So these were refractory status epilepticus without anoxic brain injury. So does the results change if we do the same analysis in anoxic brain injury is the question. So they did a univariate analysis. So there were 45 patients with refractory status epilepticus after anoxic brain injury. There they found that there was a difference when it comes to persistent seizure termination. So with patients who had complete burst suppression, 84.5% achieved seizure termination in patients with anoxic brain injury, and this was statistically significant. And the in-hospital survival was actually more in patients either with incomplete burst suppression or with complete burst suppression, and these patients this again was statistically significant. Now if we look at return to premorbid neurological function, only 2 patients returned to premorbid condition. So by looking at this table, it looks that yes, maybe incomplete burst suppression and complete burst suppression has a positive effect on outcome. But if we further analyze looking it into the Glasgow outcome scale, we found that out of the 12 surviving patients in this subgroup, we can see that the test scores were 2 and more than 3, and none actually had a Glasgow outcome scale more than 3. That means they were either in vegetative state to severe disability. So that was the improvement in outcome you achieve with burst suppression or with minimal burst suppression compared to no burst suppression in anoxic brain injury. So based on the results of this study, one thing which is glaring is, though burst suppression is defined as per the criteria, it was achieved in only 30% of the patient, and only every 5th patient who actually fulfilled the criteria according to ACNS criteria. So this gives us what we also face in our day-to-day clinical practice, that it is actually difficult to achieve and maintain burst suppression with intravenous anesthetic agents. And so seizure cessation or burst suppression is actually a clinical decision. So even in this study, the clinicians were allowed to choose whether to aim at seizure cessation in EEG or to aim for burst suppression. And next, from the results of this study, the achievement and the duration of burst suppression was not associated with clinical outcomes. In fact, the complication rates were higher. Now, when compared to previous multicentric studies, the data is mixed. So there was a large multicentric study which showed that when burst suppression was achieved, the clinical outcome was better. But if we closely look at the analysis, the outcome, the GOI score does not cross 3. That means even if the outcome is better, it's not contributing to meaningful neurological recovery. So burst suppression with suppression or attenuation proportion of more than 50% is more effective than using burst suppression with a smaller suppression or not using it at all. There is, based on this study, there is no evidence to say that achieving burst suppression more than 50% or you aim between 20 to 49% or no burst suppression at all does not affect outcome. And refractory status epilepticus. So in this study, there was a significant finding when we did a subgroup analysis of anoxic brain injury. So refractory status epilepticus after ABI significantly increase of persistent seizure termination and survival in whom burst suppression was achieved. So this again, no surviving patient had a GOS more than 4 than 5. Though it shows a statistically significant difference that patients with anoxic brain injury had a better seizure termination and survival compared to no burst suppression, the meaningful clinical outcome was not there in this study. So what are the strengths and what are the weaknesses in the study? The strength is first the long follow-up period of 9 years, and it was a large sample size, and it was a representative cohort. It consisted of patients which we encounter in our ICUs on a day-to-day basis, and the EEG assessment for burst suppression was done in a semi-quantitative visual analysis rather than going with a qualitative analysis completely. So this is more clinically what we do on a day-to-day basis. And the latest 2021 ACNS standardized critical care EEG terminology was used in the study, and the subgroup which was the differentiator, anoxic brain injury and non-anoxic brain injury, which was significant. So that was one of the strengths of this study. Did this study have weakness? Yes, because it was a single center study. The data was a part of 2 other cohort studies which were ongoing, and full EEG, continuous EEG was not available. Only 1 hour recording was taken. So what exactly happened for the start end, we don't know. So some burst suppression could have been missed during analysis, and the exact etiology and the reason for choosing burst suppression and not choosing burst suppression in a patient was left to the clinician, and it was not analyzed as a part of the outcome. So these were the weaknesses in this study. So any cohort study, so the equator guidelines say we need to go through what is called the strobe checklist for a critical appraisal. So if we categorize this article based on different subheadings, the title and the abstract did indicate the study design, and it did provide, the abstract gave an informative balanced summary of what was done and what was found. The introduction provided a good background rationale, and the objectives were very clearly stated and the hypothesis was clearly stated. The methods, the study design was very clear. The setting was described, the participants, the inclusion criteria, the exclusion criteria, the definitions, outcomes, and the variables, the data source, how it was measured, any biases. For example, anoxic brain injury was taken as a confounder in this case. All this was addressed well in the article. And the study size, again, this is a retrospective, they just took a convenient sampling for this, so the sample size is really not justified in the study. If we look at the statistical methods, appropriate statistical methods were used. Okay, and missing data, not much missing data for the data, so that was not explained in the protocol. If we look at the results were arranged in a flow. It looked at the reports of the individuals at each stage. The descriptive data was given, the outcome data was given, and then the main data along with the confidence interval was given. The interquartile range was given, the odds ratio with the confidence interval was also given, giving a clear viewpoint as what were the confounders in the analysis. Next is, if we look at the discussion looked at key results. So it compared with previous findings of refractory status epilepticus, and the limitations were very clearly defined. So what was the bias, what was the problem with the studies was also clearly mentioned in the articles, and the funding source was given, and also the conflict of interest was explained at the end of the article. So overall the article addressed all the scientific points and the ethical points in a very lucid manner. Now, when we do a critical appraisal and to understand whether an article is relevant to you in when we read through an article, it's a very cumbersome process. So how do we simplify it? So you can use a simple checklist where you look at 3 components which will affect your clinical practice. One is, what were the comparison group? So does that study address the treatment between the comparison group, and is there a relevance of the study design to the clinical population, and does the study take into consideration selection bias? The next is to look at impact of compounding variables. So whenever we look at a clinical outcome, it's very important to understand compounding variables. So the literature review conducted, and what is the hypothesis, the basis of the hypothesis should have been defined in the article, and we need to assess the baseline characteristic of both the groups, and you need to look at the methods used to identify the differences. And the third thing is, did the study have a good analytical strategy? Analytical strategy means whether the variables included was appropriate statistical tests used, and was there any biological validity of the results. So does that make sense? So these 3 questions should be asked when we read any study. So if I have to put it across in this study, in this the comparison groups were burst suppression, any burst suppression, or no burst suppression at all. The confounding variables, how it impacted the study. So first they looked at, these were the confounders which were identified, which was taken care of when they did the univariate and the multivariate analysis, which was age, Charlson's comorbidity index, and refractory status epilepticus with motor symptoms tests, and the arterial hypotension. And the third thing is, they used univariate and multivariate analysis due to small population size in the anoxic brain injury. Of course, multivariate analysis could not be performed. They only looked at risk factors, and a descriptive analysis which was described in the study result. So overall, to conclude based on the article, not achieving burst suppression was not associated with adverse outcomes. So a larger study is required to answer one important clinical question. That is, rather than having a generic term that burst suppression is of no use in refractory status epilepticus, like a hint in this study where anoxic brain injury, burst suppression, or even some burst suppression had some advantage compared to no burst suppression at all. So maybe certain subgroups benefit from burst suppression in comparison with seizure cessation as the titration goal for IVADs. So in clinical practice, what is the end goal for refractory status epilepticus? Is it seizure termination or burst suppression is yet to be clarified, but this study gives an insight as maybe there might be some condition where burst suppression might have role in improving clinical outcomes. Thank you. So with this conclusion, I would like to thank NCSI for this opportunity of Journal Club by the Classroom series. Thank you very much.